Anything in the minutes for either meeting?
I'd make a motion to approve the minutes.
Sheriff Easter moves and Representative Helgerson second to approve both sets of minutes. Any objection? Hearing none, we'll call the minutes approved. We're going to do a quick project update. I'm listed and Tanya Cole with Sedgwick County. I'll let Tanya go first if that's okay. I'll let her go first. That sounded more demanding than I meant it to. Tanya, I apologize.
Okay, well, good afternoon, Tanya Cole, Assistant County Manager. For my updates this afternoon, I have a couple of handouts for your review. I want to give you an update where we are with our architectural firm and then where we are with land. I cannot remember if I talked to you about this at the last meeting, but I'm going to go ahead and give you an update. If I did, again on this. Pulse Design and GLMV were awarded the architectural and engineering contract. And so we have started work with them actually on January 19th. So fairly recently, we had our kickoff meeting on January 22nd. And so what we're starting now is just the schematic design layout. And then starting Monday, we'll start with the site planning and design. We did have a visioneering session at the beginning of February, and the design team did take a tour of Osawatomie State Hospital. And then on Tuesday, we will take a tour of the Larned Hospital. What I have before you, the long sheet, the 11 by 17, I thought you would be most interested to see. And I'll just kind of cut to the chase basically on that timeline. So design, we are expecting to be complete in about 9 months. So we plan to finish that about mid-October. And then you'll see there will be some other things there on the timeline, such as bidding and getting the bidding done. And then, of course, getting the procurement piece. But then the construction is estimated to begin February 2025 and then be complete August 2026. So in time to, again, use those spark dollars. So then a total of 18 months for design. Scott sent me an email Monday, that was President's Day, to let me know that the governor's office did approve a 100-bed design. And so we're going to go ahead and design that, not necessarily build that. But again, that is approved to at least do the design portion. And then if we do have funding later to build the 100 beds, we'll do that. But at least we'll have the design. At any point, then we can come back later and build that out. Okay, I'm going to move then to the land and property. The land was approved to proceed with negotiations on January 26th. And I just want to go back through this just one more time. So the shortlisted sites that was assessed through, and there were 4, that was assessed through the Phase 2 evaluation criteria after the town hall and surveys, site reviews, and internal discussions. So the MacArthur Meridian shortlisted property was the overall recommendation of the evaluation review panel. So that consisted of KDAD's staff and county staff. And additionally, of course, you all, the South Central Regional Psychiatric Hospital Advisory Panel gave recommendations for consideration to the governor's office on the shortlisted sites, including the MacArthur Meridian location. So based on these recommendations, Sedgwick County staff, in conjunction with the governor's office and KDADS, moved forward with the approval of Sedgwick County Commission to begin negotiations and discussions with the Lane Community Foundation on their RFP submission of donated property of up to 11 acres of at MacArthur Meridian. And so we began meeting with Lang Realty on January 31st of this year. And I think that we talked through this, I have this, and I apologize, I didn't bring the actual GIS map. I think when we talked through this, what they submitted was the northwest area of MacArthur Meridian. And we had discussed with them on our site visit if they would be open to looking at us obtaining the southwest portion of MacArthur Meridian for that 11 acres. And after meeting and negotiating with them, they continue to be agreeable to that. And so, again, I just want to point out the pros or the benefits of the southwest parcel. The patients, they will be able to have the views of that retention area, and you can kind of see that in the middle there. That's kind of those swirly lines. And so that will be kind of a landscape and nature area. And then, of course, the detention pond area. Also, the benefits of this southwest portion is we'll have the ability to use MacArthur for site circulation. And so what that means is basically off of MacArthur, we'll have separate entries for staff and for admits and deliveries. So we're probably looking at, I would say, at least 2 entries off of MacArthur, and then most likely a third off of that access road there. And then, of course, the third piece then is just the ability to have access to utilities off of MacArthur. And we just feel, and it's been confirmed, that we can most likely get the site up quicker at this southwest portion. And so right now we're working with Lang to get through the property boundaries. As you can see, these the red kind of squiggly line and the green squiggly line, that makes up 11 acres. And so you can see that goes past the access road. And so what we're working with Lang is to not have to move that access road. And so what we're looking at is extending that green belt area, if you will, to the north to give us that 11 acres. And it works for us because the front entry of our site is going to be more narrow and the back is going to be wider. So that will work for us. And so we're working with them to kind of shift those property boundaries without having to replat that. Also working through any special assessments there for that detention pond, the utilities, the access roads, lighting, those kind of things that you would get with special assessments. And then any change to the zoning, which we know that we will have to do a change to the zoning for that area. So those are my updates on the mental health hospital for the Sedgwick County regional area. So I'm happy to answer any questions that you might have. Yes, sir.
So Tanya, do we envision that the front would be facing MacArthur?
Yes,
Okay.
yes.
Representative Huddleston.
Scott, I don't know who answers this, but what is the date? If we make a decision to move to 100 beds, what is the date you need to know that?
Well, I guess sooner the better. We're designing it now. So I guess at the point of if we go out for construction, we put out the documents for construction, which give me a minute because I need to look with. So that is around October that we would go to bid. That would be really helpful if we could put out the bid documents asking to basically construct a 100-bed hospital, because of course that would be, I think it would be efficient. It would be cost savings if we could do that all at once rather than have to go back, and build the 50 beds later.
Okay. I'm assuming that the legislature will have this discussion in the next month. So in the next month, if you have a commitment of either going to 50 or going to, what is it, 104? Is that what you said?
Mhm.
104.
Correct.
That's plenty of time in the next couple of months.
Yes, sir.
Okay. Are you gonna do it where you have, this is if we do 50 beds, this is if we do 100, or are you going to, at that time in October, it'll just be a simple 104 beds, correct? You won't be doing either option.
If we have the funding appropriated as your recommendation as the panel was to make that request, if we have the money appropriated in this budget cycle, we could go out in October with those bid documents saying build the 104. If there's some question about the funding or we don't have it fully identified, then I think what we've talked about is that the primary bid would be to build the 50-bed hospital with the support spaces, and the other 54 beds would be an alternate that the contractors could bid on what that would take to do if there was a question about the fund.
Okay.
So I think we have either option at this point.
All right, are there any restrictions on the rest of the land in the development?
And
In-
when
in
you
the
say the rest of the land,
land-
you're talking about the other 70 acres or
70 acres, are there any restriction? Or has there been any discussion about what they can put there or not put there?
not to my knowledge?
Is that worthwhile?
Having those discussions.
Well, if they put a bar there, is that good or bad for the state hospital next to it? And do you want to ever get into those discussions?
Well, I mean, there is a vision that the Lang Community Foundation has for the 70 acres that is compatible with the state mental health hospital being there.
Okay, thank you.
Sure.
Senator Reddy.
Yes, thank you. Appreciate the presentation and a follow-up question to what was just asked. What is the number that you need as far as the funding appropriated to go with 104 beds?
Senator, I don't know that we actually have that particular number, but we can push, I think, the architects a little bit further. We have basically an estimate right now of what they're seeing right now with the cost of new construction on behavioral health hospital. So right now it's an estimate. And so I think if we need to drill down a little bit further and get a little bit closer, I think we can certainly do that. I think if we give you a number right now, we just have to understand that's just based on a very on a square foot number.
Yeah, sure. So just to follow up to that, I think it would be good to have some kind of a close estimate. So because appropriations and everything is starting right now, and we may, if you're saying we should have at least some kind of appropriations looking at this for in our budget, it would better to get those conversations going, because I think it'll be harder to build it after the 50-bed is done and then add on to it. So it would be, I just would like to have a number. Are we going to get the funding or not? I'm not sure, but I would like to certainly look at it. So that's my request to you all. If you can get us a number closer to what you might think 104 beds would be.
Okay.
Sure. No, fair request. Where we are in the design. So the estimate was based on the design that we've shown you before that was done last summer in the kind of discovery process that we've been working on the last couple of weeks. We've added a few things. I don't know that we've subtracted anything, but we've added a few things that we didn't get in that original design. So we do want to go through that process enough to have a better sense of what the total square footage will be. But I think we're close to having the ability to do a better estimate.
Great.
But I
Sounds good.
appreciate,
Thank you.
I just want to, we don't have to vote, but it does sound like, or I'm not hearing any objections from the panel to pursue putting an estimate out there for the 104 bed construction, assuming we want to build all at once as opposed to building in phases. In terms of direction from the panel.
Yeah, I would make a motion if that's what you need.
Well, maybe we'll let that sit out for a little while, and if there's an interest in making a motion about that before we adjourn, we can certainly do that. And do want people to give that some thought along the way.
Thank you.
Do you know if we are looking at the $15 million that would be for operational use for this hospital? Is that money that we're looking at to potentially go to 100 beds? Or do we have the ability to use that for this, since it's for an operational the budget going forward?
We can use all of the funding that's appropriated for operations for construction. So we can that will not get us to the 104 beds on its own.
Yeah. Okay, thank you.
And then we've got to figure out how to pay for operations once we open it, which would, if so we can't use the money twice, but there's not enough. I think just our back of the envelope, we can use the $15 million from last year, this year, and the next fiscal year, along with the spark money. That gets us the 55, yeah, or 50 bed construction. Other question, Tom?
Scott, I was having a discussion with the city manager earlier this week. This site, this MacArthur site, are there other, this is the site, right, for the hospital? Is there any other sites being discussed for this hospital, or could it be discussed in the future? I mean, or does the community be aware?
So there is some, I've been approached by some members of the legislature that have been in discussions with the owners of the Riverside Hospital discussing it as a site for this hospital, for our construction. So far, it's just been discussion and the direction that I've gotten from the governor's office is to work on this project as we've designed it. So that's what we're working on, and that's what we're working with the county on right now. But there are some other option at least being floated around to members of the legislature that we're aware of, that I'm aware of. Other questions?
I guess to that is there a consideration that something else could happen with beyond moving forward with this? Because I'm also hearing some of those same things.
So, well, I don't want to put you on the spot. The legislature could, they're the appropriators of state money. So if they wanted to provide different direction through an appropriations process, that's a possibility. The governor, we've raised the discussion with the governor's office, and they've said they're not interested in that as a discussion. And if it comes through the appropriations process, well, the governor would act accordingly to show the commitment to this project or take that out of the budget. So it's a discussion. There's some interest in having further discussions about it, but right now I'm working on this project. If you'd like to, Representative.
As you're well aware, there could be 125 different proposals in the House and 40 in the Senate. I'll be very upfront. I was asked to go through a tour of a different site. So were some other legislators. There was some consideration. I also visited with the governor's office, and as I understand the governor's directions to the department, we're on track to go this direction. And that's my instructions at this point also. Now, are there other legislators that may be trying to go a different direction? Yes. And I'll be very frank, Tom. I've told them, I said, we're going to need a dollar for dollar comparison before you even get in the front door. We're going to have to look at you. The committee's already made the decisions. We're heading in that direction. We, meaning I'll say the governor's office and the legislature, and to overturn that, you'd have to have something overwhelmingly better that presented itself to the legislature, to the county, and anybody else involved. Right now, that has not happened. Could it happen in the next few weeks or next month? Yeah, but right now, the governor's heading in this direction, and so am I.
Can I just add, I think these conversations have been going on for some time, for a couple of months, kind of behind the scenes on, not necessarily from us or the commission, but people behind the scenes trying to look at other options beyond what we have decided to move forward with, either from this advisory panel or for the commissioners or from the state, from the governor's office on where we want to go. I do think it's important that we have this conversation publicly, because when they started, they didn't really have any feet under them. And so I didn't think that it was possible that it would get any traction. I think that could be changing a little bit today. The Riverside Hospital owner, his lobbyist, which is Michael O'Donnell, is working with state legislators to find a way to go to Riverside instead of the location that we have decided. The concerns are there primarily because that's not going through us, which this is what we've been tasked to do by the governor's office. And they're not going to the commission, and these conversations are happening even though we have already laid out a plan going forward. The commission has had this conversation, and I'm not going to say that we're going to do one thing or the other, but I will say that if this goes to the Riverside Hospital and it does not stay at the MacArthur and Meridian, because of conflict of interest and all the laws that go along with ARPA dollars, the county will have to step out of it. We are not going to put our citizens in jeopardy of hurting us either with our credit ratings or future funding from the federal government. The other option of going to Riverside is now so out of scope of what we can do and legally do within ARPA dollars that the state legislator is going to have to figure out if that's the route that is intended to go, where the money is going to come from, because it won't come from ARPA. The only reason we are involved is because we applied for those ARPA dollars and we would build the facility. It is very frustrating on our end when so much work for so many years have gone into where we're at today, to watch people put their hands in this that should not be doing that. So there are frustrations on our end at the commission on just what this looks like going forward with that path. I will say there's no indication on our end that we are changing what we're doing. We're still going down this path. I think the state legislators could throw a wrench in that if they so decide, but I don't think the governor is on board with that either. So I think we're still very clear on momentum, on direction, on where we're going, on this is, going in the location we've decided. But I do think it's important that people are understanding the reality of the conversations and the politics being injected into this conversation, which is really sad because it's such a desperately needed thing in our community to have this hospital. So I am glad that it got brought up. I did want to make sure that we had that discussion so people know that if ARPA lines are crossed, Sedgwick County will have to exit this process, and not because we want to, because we have fought for this for so long, but we will not put our residents in jeopardy if that's where it's at. So, but again, I don't think we're there today. I hope we don't get there. I hope we don't have to make those decisions going forward. But we're ready to if we have to.
Well, what I'd like to add to that conversation, because I'm just now kind of finding out who's involved and what's going on. We profess here at Sedgwick County to be very open and transparent. And during this time frame, with this committee, with Scott Bruner, with KDADS, with the county, we have been very open and transparent. We've held community meetings, we've held surveys. I've never seen a single survey from Michael O'Donnell or the owner of them. I have not seen them at any of our town halls. This appears to be backhanded politics, which I cannot be involved in. And so I represent a law enforcement agency. We actually have morals and we actually have ethics. And so I guess what I'm saying is if this keeps pushing forward with that particular group, I'll have to step down from this board because I will not be a part of that type of conversation that's not open and transparent, that's backhanded in my opinion.
And I also think, to be clear, I mean, the city is looking at Riverside for their MAC project. I think it's very important that we recognize if our project gets thrown off, so this hospital can go there, so does the MAC project. I mean, these are two very important things that are happening in this community right now that have been needed for many, many years. I would hate to see both of them get derailed because of politics getting injected where they should not be in something so important. So that's all I have to say about that. But I just wanted to make that very clear where the county is at, because we cannot put our residents in jeopardy.
Thank you for those comments. Any other questions for Tanya? Sorry, I asked you to go first,
That's right. Thank you.
but thank you for your update. I don't want to belabor things too much more. I did want to add just a couple of items from the state's update on the project. We've been working internally with a pretty broad team of folks from my staff and the teams at Larned and Osawatomie to revise the staffing model for the new hospital, both we've been working from the 50-bed model, but we can scale it up, we think pretty quickly. So I feel like we're very close on that. We've got a couple of elements of more operational support for the hospital that we're trying to figure out whether we want to build that as state staff or contracts and what the cost would be relative to those things. But we should have that for you to look at I'm going to see if Irina has a panic attack when I say we're going to have that for you when we meet in March. But I think we're on a good track there, which is relevant to the discussion we'll have today about workforce. We have been meeting with the design team. We've got the schedule that Tanya talked about with Pulse. It's aggressive. It goes into a lot of detail, has to, for every space, function, room, flow of the hospital, and to get the best possible review of those things. We're asking lots of nurses, social workers, our psychologists, our medical staff at Larned and Osawatomie to be part of that discussion at different degrees, but really dedicate their time to making sure we get it right in the design, so it works well and we can take advantage of the site. So there are going to be a significant team of state hospital folks working on the design. And then Tanya mentioned it, the design team, the architecture and engineering team have already been to Osawatomie and toured the campus there. We're going to Larned on Tuesday to look at the equivalent programs on that campus. Anyone else who would like to come is welcome, or if you can't make it this week and you'd like to come out and tour either campus, you're certainly more than welcome. We'll be glad to invite you to that. But at least I didn't attend the Osawatomie one. I'll be at Larned, but the architects learned a lot, asked a lot of questions, raised some issues that we needed to address as well. So that's been a very productive process. Last thing I have is, so Monday night, we are having a town hall meeting at South High School to talk about the site closer to the MacArthur and Meridian site in South Wichita. It starts at 6:30 on Monday at South High School. The presentation will be pretty similar to what we did in December, with relevant updates that we've got in the meantime. But we'll take public comment. We'll have people do things in writing or fill out comment cards, and Monica and the Greenbush team will help kind of not filter those questions, but sort of summarize them so we can answer them effectively. So I would encourage you to send that out. We can give you the social media posting or the flyer if you'd like to distribute those things, or certainly attend as you're able on Monday night. Any questions for me? Yeah, Claudia.
Maybe just a comment. I don't know if it would be helpful, but if the architects would like to tour, our Via Christi site, the 6th and 7th floor, it might have some contemporary design and also the activity spaces. So it's close, if that would be of interest.
No, thank you. So they have talked about other hospitals that we would like them to go look at that are built, in this century. So that we appreciate that.
Got another question from other constituents who've been talking to me. In our design and in the staffing models, we are being considered a CMS certification requirements in this moving forward.
Yes.
Great, thank you.
For the care and treatment side, we would be certified. For the forensic side, that's not required, but we're going to build to the CMS standard across the whole building. Other questions for Representative?
I understand the previous discussion that we've had, but I'm going to go a little bit different, and that is, what happens if the legislature and or the governor decide to expand it more than 100 and some beds? Do we have the space available in that facility? And has there been any discussions with landlord, architect? Because I know that discussion is going on behind the scenes, that 100 is not going to be sufficient. And if we've already made the decision and are committed to staying in this location, how is it possible to still add more eventually into this location?
I think if we don't have enough on the site itself, if we build one floor, if we go vertically, and we talked about that with the architects of stacking the patient units on top of each other. So there is an upper limit to that, I'm sure. We did talk to the Lang Community Foundation about the size of the building and how many stories it would be. I don't remember that was a concern. They just were curious, I think. But so for this site, the only option would be to go vertically. Unless Tanya remember something else. Okay.
Does that change the constructional dynamics such that you need to know it by a particular date?
Absolutely.
Yeah.
Yeah, we would have to know, I mean, as soon as possible if we're going 2 stories and if we're building upwards of more than 100.
Are you asking for this moment or just in general in the future? I think that would
I think
change that conversation.
There has been conversations that the facilities we have clearly are outdated. And if we're building a new 100-bed facility here, and if we're trying to build a pipeline of staffing, we need additional beds. This is the likely place. And we should at least consider that now and in the future. That if we're going to add on another pod, or is it possible, or add on 2 pods and just duplicate what we're doing, is there space to put that in that area? Or do we have to go through all of this again?
Well, I think we
Well-
can build up. I mean, if we have the pods as they are today, we can add another stack on top. I know the conversation around Riverside because it has more beds. I don't know, Sheriff Easter, if you want to speak to the security concerns and the long-term costs of creating for Riverside to be something that we can actually use that will be secure.
And I'm not talking about Riverside. I'm saying that when I look at your budget, and we're doing things with your budget right now because of the problems we have. If we decide that we're going to have in 2 years, 3 years, 150 beds or 200 beds there, because we can't staff them somewhere else, which we can't do right now. We need to at least this group needs to think through that now, rather than coming back in 6 months and say, hey, this is what we're going to have to do. That makes sense. And I'm throwing Riverside off the table. I'm just talking about this site that we have, and can we add on to it, or what do we have to do?
So, Tanya, I don't know, or Commissioner Lopez. So our jail currently is stacked. It was built originally to be able to stack on top. That's very doable. I understand that it's more expensive when you go up. But, from a standpoint, and I've said all along, and that when you build a mental health hospital that's for the folks that are going to be housed in there, it has to have the same safety and security measures that you have in a jail or prison. There comes a lot of cost with that. And so because it's just not brick and mortar, there's a lot of steel, a lot of other things that people can't drill through, those type of things. So it is a more expensive proposition. From a safety and security of being 2 floors, we don't see that as being really an issue inside the jail. Yes, hopefully your elevator's working, but you have staircases that our staff can get in and out of really quickly, that half the time is quicker than the elevator. So from a safety and security standpoint, I don't see that as an issue because we operate in that every day, and it's not been an issue for us that they're stacked on top of each other.
Senator Reddy, I'm sorry, you had your hand up before and I missed it. I apologize.
No problem. I just wanted to get back to your discussion on workforce. You were talking about providing some kind of a staffing model or something of that sort in March, and including others in on that, as far as other staff from communities across the area in similar fields. I was in a meeting this morning with the veterans claims. I'm on their advisory board, and currently they're fully staffed and they're nursing, LPN, CNAs and such. And I was asking them how they did it. And I don't know if we have certain structures in place but they offer, you know, for some of their LPNs or CNNs, tuition if they want to go for higher degrees in that healthcare profession. They have different models of staffing. And I know there was an email sent to be on a subcommittee regarding, one of them was workforce, and I had signed up for that. I wanted to know if we are looking at all of those measures and talking to our schools right now so that we have graduates by the time this opens to automatically say, you know, if you graduate or if you have high school students that are planning to go to be into this profession, that they have an opportunity already given to them to have a job once they graduate. And if that's a discussion for the workforce subcommittee, I'm okay with that. But I just want to know if those are discussions that are taking place.
Sure. No, that's, well, we asked our guests today to think about or give us their thoughts on that kind of pipeline questions. We've talked about that internally as well of, you know, building skill, growing our own from direct care to through nursing, through psychology, through social work. Those are all certainly on the table, but I think we'll have more content around that here in just hopefully a couple of minutes. Yes, Tom.
I've got one quick technical
Thank you.
question back to Representative Helgerson's statement. Tanya, can we ask Lang if there's additional ground as an option? I don't know if we have authority to do that, but can we ask that question? Is that proper?
Yeah, we can certainly ask them. I mean, and I alluded to this before, that there's a vision out there for that entire, 70 acres, but I can certainly reach out to them. The other thing that I might just add is the sooner that we can know if we're going to 150, 200 beds, because as I'm kind of envisioning what we had designed for this, as I see that kind of being stacked, I'm just thinking they may have a completely different design feature to this. Because as you remember that it was kind of like a hands, and so if you double stack that, I'm seeing, you got elevators all on these. They may have a completely different vision if we're going to go 200 beds double stacked, where it's a little bit more efficient where they could do something on that 11 acres. So I just throw that out to you. The sooner that we can know, because you're kind of blowing my mind here a little bit, sooner we can know, the better. I hear you. Thank you, Representative.
Other questions? I got through my updated items. I mentioned the town hall on Monday, right? That was okay. You're doing a great job using the microphones as well, which Nicole reminded me I needed to remind people to use, and I haven't had to do that yet. So thank you. Thank you for that. We can certainly continue the conversation afterwards, but we do have some guests that I'd like to introduce and move on to. So we're going to start focusing on workforce issues today in pipeline. So we've invited some guests. I'm going to ask Monica to kind of lead us through that next phase of the meeting.
Hello, everybody. Monica Murnian from Greenbush. We work today to bring you some experts in the field of workforce, specifically in the pipeline, the educational pipeline. So we worked with a lot of different people to find out, who's in the know on this. And we were pleased to bring you 4 different groups of participants today. They're each going to talk to you about 15 minutes and leave another 5 or so for questions that you may have. Their charge was, hey, do you have any solutions? And could you bring them? It's amazing they showed up today because that was the task. Also asked about specific barriers, specific opportunities that this group might want to consider as you move forward from their very real life day-to-day operations. So we have 4 groups that are visiting on different components. And the first person that we've asked to visit with you today is Lynn Loveland from WSU. She's the health science, WSU Tech, and she's the Dean of Health Sciences. So thanks for being here and thanks for sharing your knowledge.
Well, I too am now questioning why I showed up today. So anyway, thank you very much for inviting me. I'm here on behalf of Sherry Utash and the WSU Tech campus to talk a little bit about my seat in the park, which is workforce pipeline. And when you talked about 50 beds, I was going, okay, so how many people do we need to staff 50 beds? And then it was 100. I'm like, okay, times 2. And then now you're saying, who knows how many? And I will just tell you, it takes a long time to ramp up a program and have people graduate to be able to staff these types of facilities. So the sooner we can start working on this, of course, the better we are. And there is no disagreement that this is a crisis situation for our community, for the country. And so many people are suffering from mental health illnesses that are not even diagnosed, let alone the ones that we know about. There has been a lack of confidence in the mental health system. Facilities have closed, jobs have gone away, and the public is aware of this. Our students are aware of this. And so to try to entice them to go into this field is going to be difficult, not just with that, but also there's a lot of misinformation and stigma about mental health. And so perhaps it's not the most attractive area. It has to really be a calling, not just a job, for you to really stay in this type of educational endeavor. There's a lot of lack of funding, private insurance or self-pay, and so that makes a difference. And also such a high caseload that we have a lot of burnout. People who are working in this area, poor reimbursement rates for providers. So all of this goes into the news. Our students are very aware. And so when they're deciding, well, I'm a caring person, I want to go into a profession to help somebody, what do I want to look for? What do I want to be? And if you plug in on the computer mental health jobs, areas I could go into for mental health, I mean, many different jobs pop up. Each one has a different title. And so when you dig down, you try to figure out, so what kind of experience, what kind of degree, what kind of education do I need? It's very difficult. It's very difficult to figure out what your career education path will be to get where you want to be successful. It's easier, I think, if you're looking at university level, master's level, PhD, that is pretty well prescribed. But the lower levels of careers for mental health are very diffuse. And that's much different than it is for, let's say, nursing. When we typically think that the CNA is the first step in a nursing profession. And if you Google CNA, you know exactly what you need to do. It's very well laid out. You know what the opportunities for job employment. And then if that works out well, then you go, well, maybe I'll go to the next step, which is LPN, and then maybe an RN, and you progress up the ladder. Mental health is a little more squishy. It's hard to really figure out where the next steps are. And I've been in several different conversations where we talked about needing some kind of career ladder where people can learn to navigate what step is next. So you're a student thinking, well, okay, what kind of career do I want to go into? Well, for CNA, it is a 5-credit-hour class, which could take anywhere between 4, 8, 10 weeks. And so you can get through that relatively quickly, enter the system, and work with residents. And you make about maybe on the average $30,000, which is not a lot of money, but you went to 5 hours of training. So very short-term investment. Some of the mental health positions that you can go into are 45 hours of training, much more training, much more expense. And you can make about 31. So if you do the cost benefit analysis, it seems like nursing might be a more attractive profession because you can enter it more quickly, you get paid more. And of course, as we all know, with COVID, the nursing profession has reaped the reward of staffing because there's a premium that people pay for nurses. The other thing I want to say is that we have a problem securing faculty for that very reason. I have been looking for a faculty member to work with our short-term health nursing programs or CNA programs for over a year. And I do have people who are interested in teaching, but when they see what the salary is, they say, I just can't afford to take a pay cut. They're working at a long-term care facility now, making $20,000 more. So that's their mortgage payment. So how do we compete with that? Student interest, I talked about that already. And then just the lack of training opportunities. We don't have any schools for LMHTs. I mean, it's very difficult because we didn't have the clinical sites because all the hospitals were closed. So it's just kind of compounds itself into how do we really try to fix this program. So even if you have students who want to go into the program, we have to find faculty who are willing to train them, and then we have to find clinical sites where they can be trained. And I think we are gratefully moving to the place where hospitals and educational facilities are working together, that we would provide the didactic training, and then we would go to a clinical site and they would help provide the hands-on training for that. So that partnership is going to be critical if we really want to move this forward. So the employment data right now, when we go to KBOR and ask to have a program approved, they ask us to pull the employment data. And right now, it shows very little growth in the mental health industry because there are no facilities. They don't plug into their equation the new hospitals that are coming up. So we just need to make sure that we can educate them on future demand. Because if we wait until we have those jobs and we see that we're in crisis mode, we are way behind the 8 ball as far as educating our staff to help with this. So I would say just we need to make it easier for the students to enter the educational system, let them know what the career track is. We need to make sure that they have well-paying jobs, and we need to streamline titles if we can in industry, because it's just too difficult for people who are maybe not as familiar with healthcare and all the acronyms, the different positions, to really understand. And so apples to apples, they might choose another career path where you're not working with maybe so many difficult patients. I mean, it's a very difficult profession. And there's areas on substance abuse that we have to worry about because that feeds in to mental health. There's homelessness. And so it's just a huge pyramid of problems that lead into this. And if you're committed, if you love the work, it's very rewarding, but it's also very difficult too. So I don't know that I have any real magic wand that I could wave to make this problem go away. Just know that it is difficult from all areas. And our mission at WSU Tech is to train the workforce. And we do a lot of work with the entry level and really changing people's lives who thought they couldn't be successful in college. I mean, that is our mission. And we take it very seriously, and we certainly want to be part of the solution to do this, but it's going to take dollars, and it's going to take support from industry and from legislators, and perhaps changing some regulations so that we all can be successful and make this the optimal place to receive quality care for mental health issues. That's really my remarks. I didn't see any white paper waving, so I feel good about that.
You passed.
Yay.
I told all the speakers that Ryan in the back is gonna wave a little paper when it was time. Do we have any questions for our friends?
I don't have a question, but just a comment to add to what you're saying as you were talking about the employment data and not recognizing maybe facilities in the making. And I think unique not that it doesn't exist in nursing, but you also unique to mental health care is the vast majority of positions are in the community for this type of work. And so as you think about capacity building, being very mindful for those of us who are in this space that that is the biggest deficit we have. So staffing a facility is one issue, but making sure that there's continuity of care when that's done is critical.
Absolutely.
I have a question.
Sure.
I know that WSU Tech has been doing some work on the manufacturing side of things with apprenticeships. Is that something that we could look at for health as well? I mean, I know those are such great opportunities for people to still be able to go to school and have a paycheck. Is that something that we should be looking into further within WSU Tech in the state? And I guess, do you see a path forward to do that in health?
Yeah, it's a little bit more difficult in health than it is in manufacturing or aviation, which we have been very successful with that. Some of the professions don't really approve of having students be paid while they're doing their clinical rotations. So that can be a roadblock for us. Claudia, we worked on this a couple of years ago. It's more difficult, but we think it's a good thing to keep pursuing. And maybe we'll have to make some changes in some of the rules with the Board of Nursing, KDADs, to see if we can't find a way to still educate our students and still meet the guidelines that we are subject to as far as our training and our accreditation goes.
Okay, that's helpful. And then my other question is, is there any work being done to, I've heard that, and you kind of touched on it as well, that to get the educational component to have someone to teach those classes, are we doing anything right now to help with regulations on what those people, the education that they have to have? Or, I mean, is there anything being done to make that piece a little bit easier so more people would maybe be able to teach those courses, like a CNA course or something?
You mean as far as different criteria for faculty? We did have a pretty successful, intensive project a couple of years ago to change the faculty that are able to teach CNA. And we did get it through that now LPNs with certain different criteria are able to teach the CNA course, not just an RN. So, but it did take, I will just say, it took a little bit of time and some lobbying and some blood, sweat, and tears to get that through. But that is something that we are able to do. The accreditation body is different, and some of our programs are accredited by national organizations. And so that is more difficult to try to get them to, because patient safety is really their first priority, as it is for us. And we want to make sure that we don't compromise that in any way, yet still provide students the opportunity to learn, earn some money, be able to support themselves while they go through this educational process.
Thank you so much. Appreciate your time.
Thanks, Lynn. You
Okay.
brought, you did it. You did it. And thanks for your time on this beautiful
Yeah,
afternoon. We
thank you.
appreciate your perspective from WSU Tech. And next we have a tag team effort of Dr. Gabrielli and Dr. Mayorga May, who are coming to us via Zoom. They're giving us a perspective from the University of Kansas School of Medicine. Thanks to both of you for joining us.
Thank you very much for having us to talk with you. I am Bill Gabrielli. I have the privilege to be the chair of the psychiatry department here at University of Kansas Medical Center in Kansas City. And Dr. Mayorga is vice chair of the department and the director of residency training. We have, if I can share it, we have some slides to help us with talking through what we want to talk about. Over here.
Yeah, we can see the slides, Dr. Gabrielle.
Yes, are you seeing the slideshow?
Yes, we
Or-
are.
Okay, great, thank you. This is looking different here.
You just hit it from the beginning again.
There we go. All right, thank you so much. Yes, and we are planning to talk about the staff, the medical staffing. We also at the KU Medical Center are involved in the pipeline of psychologist training too, but we're not planning to talk about that today. We could do that later if you like. So Kansas needs psychiatrists. I think that's pretty clear. If you look at the numbers, we have only 300 for the entire state of almost 3 million people. But most of them, those folks, are in the northeastern part of the state. Many counties have none, and Southwest Kansas is the worst part of the state in terms of the availability of psychiatric care. Okay, so the pipeline for creating a psychiatrist, and you will need psychiatrists to staff the state hospital. The pipeline takes 12 years of training after high school. So that means 4 years of college, 4 years of medical school, and then 4 years of specialty training in psychiatry. In Kansas, we produce between 8 and 16 doctors a year. I'm saying 12 on average, from the two programs, the two residency training programs, the one we have here in Kansas City and the one that you have there in Wichita, that Dr. Lincoln will talk about a little later in the program. Half of these individuals, we think, it varies year to year, leave the state, and there's a few that come back into the state from training in other places. My impression has been that we're pretty even, maybe to a slight producer for other states of psychiatrists. But then it's worth noting that a fifth of the psychiatrists in Kansas are over 65, as I am, and those folks are retiring, and they're retiring faster than we're producing new people. So it's important for us to not only staff the state hospital, but to produce more psychiatrists for the state in general. I'm tag teaming this with Dr. Mayorga. She's going to jump in, and you're all welcome to ask us questions as we go, and we're honored to take questions at the end too. But I want to point out that the state of Kansas and the state hospital system, specifically the Topeka State Hospital, before it closed in 1997, and I was already chair at that time. I've been around, I'm a dinosaur. The state supported psychiatry resident physicians. They worked at that facility. They were enrolled in the Menninger School of Psychiatry, which also had its training of residents in Kansas. And for several years, part of the closure commission and the laws related to the state hospital closure, the state supported some of those residents who were then designated to work in some of the community mental health centers, the Wichita, Topeka, and 2 in the Kansas City area were supported by that program for a while. And then administrations changed, the restructuring happened. People forgot why there was a commitment to those residents, and the program ended. So I'm going to have Dr. Mayorga take over now and talk about what it is in terms of inpatient hospitals, and maybe a little more about what residency training is.
So psychiatry residency is a 4-year program, and part of that residency program is inpatient care, which a state facility would be. It's an inpatient hospitalization, but there are limits. There's in residency, you have to have a minimum of 6 months of inpatient training, but there is a maximum. It is 16 months of training. And you cannot have residents go over that 16 months of inpatient training. So it's part of the training, but you can't have someone on an inpatient unit for 2 years in a row. That oversteps what the rules are from our accrediting bodies. They also have to have consultation liaison work. They have to have outpatient work. So there was a trend in the United States of residents having a significant amount of inpatient training and not a lot of other, which is why they capped it and said no more than 16 months on an inpatient service. Inpatient experiences are best across the spectrum of hospital types. We've got university, VA hospitals, community hospitals, county safety net hospitals, children's hospitals, and state psychiatric hospitals. They are good training sites across the country. We have residents in our Kansas City program that do elective work at Osawatomie or that moonlight at the Osawatomie State Hospital, and they just feel like what they learn there and the patients that they see is just such really great training for them as they look to becoming staff psychiatrists. So state hospitals provide very valuable experience because of the unique patient populations that are there. Our home hospitals are acute care. Patients are there, 5 or less days. And also the exposure to forensic circumstances in the state hospital which is also a training requirement. Taking care of involuntary patients, talking about competency, guardianship, things like that. That's all part of training required in the residency program. When you're thinking about the inpatient time of a resident, it depends on the year, how many patients they can take care of. So as a first-year resident, on a month of inpatient, you might be able to take care of 5 to 7 patients on your own panel. As a second year or above, maybe you go 7 to 9. Residents can't see 15, 20, 25, 30 patients a day. There must be a balance between service and education, with education being the key in residency, obviously to help see patients, but education is also very important. As with all psychiatric hospitals, residents have to be staffed. This is how we create new attending physicians as they come through residency. Very often when they rotate through the different sites, like the state hospital, they will fall in love with it and say, this is where I want to be. When you look at the sites that our residency program goes to, the Kansas City VA, some of the community mental health centers around, we have so many of our graduates in the community because they fell in love with the site that they were rotating at. So this is a pipeline for future physicians who will staff the state hospital by having them rotate through the state hospital during residency. So in addition to a medical director, sufficient medical staff are required to evaluate patients and order medical interventions. Physician staffing is usually provided by employed physicians, contracted physicians, or privileged physicians. Resident physicians can provide medical services for hospital patients under the supervision of program faculty providers, thereby extending the number of patients cared for by faculty providers and simultaneously giving the resident physicians valuable experiences. So you may have a faculty member who, would say, hey, I can see up to 20 people a day, but if you give me a resident, maybe I could see 25 or 30 people because I would have someone who was helping me see the patients. So it as kind of an extender.
And a supervisor can supervise more than one resident. Say, maybe 2, maybe 3, maybe at most 4 probably, but it is possible to do that. But now, Dr. Mary, talk about what is different in terms of what's required of the supervisor.
So the supervisor, the faculty physician who is supervising the residents, must have full licensure and must have psychiatry boards. It is an ACGME, our accreditation body requirement, that the physicians who are supervising the residents are board certified and have full licensure. Residents cannot be supervised by nurse practitioners. They cannot be supervised by psychologists. They must be supervised by physicians who have these qualifications. Now, that doesn't mean that the residents can't work with nurse practitioners and psychologists. We encourage that interdisciplinary teamwork to take care of patients, but the actual staffing of the patient and the deciding the medications and what the treatment plan is going to be has to be provided for a resident by a physician who has full licensure and psychiatry board qualifications. Other things to think about when you're thinking about having residents at a facility. When you do resident rounds, it takes up more space, right? Sometimes residents, sometimes medical students can follow those residents, but you have faculty members and residents and medical students and maybe some pharmacists who are all going to round together. And so being thoughtful about a big enough space for this teamwork to happen. When you're just a private physician who's going in to see patients, you have your own little office, maybe you stop and talk to people. You don't have to have a bigger space, but be thoughtful in your design about thinking about spaces for people to have rounds if you're going to include residents, and also just be thoughtful about whether a call room or two is needed. ACGME, our accrediting body, is always concerned about fatigue and the possibility that a resident might not be able to drive home because they've been taking care of people for a long time and they need a space to be able to take a nap. Or if the weather is bad and they decide that they need to, if they're going to work Monday and Tuesday, but it's supposed to snow, they might need to stay.
It's my belief that I think the specific needs of the new hospital in Wichita can probably best be met by the medical school in Wichita. I think some of the principles that we've talked about may apply across the spectrum of the state hospital system. Let me also say that here at the University of Kansas Health System, we license and staff our psychiatric beds as acute care beds, which means we provide equivalent care and service, programming and treatment 7 days a week. And all patients are seen by a doctor every day. That isn't required depending on how the hospital is licensed. If it's licensed as a psychiatric hospital only, you can back off that a little bit. And so what the numbers Dr. Marigo was talking about, maybe 6 to 8 patients a day is the daily number. And if the person doesn't need to be seen that day, that doesn't count. So there's ways to, depending on how you structure things, to extend further. We're thinking that it's important to remember the pipeline, that the state needs it, and the state hospital is a great opportunity. It may be that some of the forensic opportunity that can be provided might not count as inpatient months, depending on how that's structured, but it probably will. But there are good ways for a good program to use a state hospital as part of the training program to expand the pipeline. Now, if the state supports, let's say, 2 residents at the facility full-time, all year long, 2 people, that's 2 more people that our residency programs can train per year, right? So you think about it as a 1-for-1. By that kind of investment into those doctors who are providing service, is also an investment in more psychiatrists for the state.
Every year we have more people apply for psychiatry residency in the state of Kansas than we have spots to be able to offer them. There are physicians all over the country who want to be psychiatrists and don't get the opportunity because we don't have the same number of residency spots for people who are interested. So growing this
by a big number.
Yes.
I mean, the numbers of applicants are substantially higher than the number of people we take into the program. Qualified people are turned away.
Dr. Gabrielle and Dr. Merrick, Scott Bruner, could I ask a question?
Of course, thank you.
So I think I understood what you were saying, that so for the resident has their program's 2 years. They can do inpatient for part of that, but they can't do it they couldn't be in an inpatient setting for the full 2 years. They've got to have other experiences, which makes complete sense. It's probably a dumb question, but if that student was able to get an inpatient experience in the Sedgwick County area at, let's say, the new state hospital, and then they wanted to go work at ComCare, for example, in the community mental health center setting for 6 months as part of their residency, and then maybe do some other community-based work or work at the VA. It doesn't matter about the area where they do the residency, just they have to have the variety of experiences.
They have to be enrolled in a program. It takes 4 years, and it's 4 years worth of different experiences.
Okay.
So, but they can spend about a year of those 4 years in a hospital. And it's absolutely true that all of the residency programs assign people in rotation to the different locations. So what we would do, a residency program would do in a situation like this, is that we would rotate the pool of residents that we have across the different sites. And so you might have one person there for 6 months, and they would be replaced by another person 6 months later, and another person 6 months later. So for each position. So there's a constant stream of people assigned there from the training program.
But the county could, for Sedgwick County, if we wanted to build a pipeline for psychiatrists that would want to either stay in Sedgwick County or move to Sedgwick County, if there was a 4 years worth of structured of locations to do their residency practice all in Sedgwick County. And by the end of that 4-year period, they've lived in the county, they've developed roots here, they've seen where they want to work, then they graduate and they can pick a job at one of the places where they worked, or no, they don't want to work in those places, but they want to stay in Sedgwick County. So we can look at it as a workforce development for the county as well.
Well, and Scott, this is Joan. We do get 3rd-year residents every year. We have 5 to 6 every year. That is our pipeline. All of our psychiatrists that we've hired are from KU.
That is absolutely the right way, Mr. Brewer. The way to do it is to actually give people experiences. We know from our experience that rotating doctors through our community mental health centers, and even those at times at Osawatomie, are more likely to want to stay and practice in those sites. And so it is absolutely true. Now, of course, the residency program during the 4 years will not just have community mental health experiences, but they'll have psychiatry clinic experiences. They'll have experiences doing consultations. They'll have experiences doing neurology and other medical specialties. And they'll get exposed to a lot of things. I know we're probably close to out of time, but I want to also point out that during these 4 years, when we're talking about resident physicians, we're talking about licensed physicians. They are licensed as resident physicians under the current structure in Kansas. Some of them in the later years, last year or last 2 years sometimes, will have an independent license, and they'll be moonlighting at various different places. But they're physicians. They're doc MDs by the time they start the residence.
Thank you both. Do we have any more questions for anybody?
Irina had her hand
Oh,
up.
sorry about that.
My team. Go ahead, Irina.
Hi, Irina.
Hello, good afternoon. It's a pleasure to see you. I have a question, Dr. Gabrielli. So if there are so many applicants, and this is great to hear, is there a potential consideration to growing the program itself? I understand it might not be a short-term solution, but if there is such a huge interest, can we do something to grow it in the
So
future?
yes, we'd love to grow it. That requires money. And so to have a resident right now costs about, like in any particular sites, to include their training costs and vacation, all those sort of things, costs a little over $100,000, which is a lot less than a physician
Per year.
per year. So when I have the community mental health center say, hey, we want a resident to come out to the community mental health center, then they pay us $100,000. I can add one more resident to my class of residents, and we send them a resident every year. So if there's people out there who are interested in funding residency spots, we can absolutely grow the residency program and take more people to produce more residents.
Yeah, and it's not just increasing the number in that way, which it absolutely is. But doctors working in facilities like the state hospital or the VA or the community mental health centers, other places, we find like to be faculty in a medical school, right? And that's part of what that gives them. You can attract, maybe it's the wrong word, but a higher caliber of provider, because they get to not just take care of patients, but they get to be faculty mentors for our residents.
Thanks for that information. Great question. Do we have any other questions? Thank you both. You could bring a really unique perspective, and we appreciate your time today. Next on our expert panel, we have Juliana Reischik from, she's currently serving as the Chief Nursing Officer of Providence Medical Center, and is going to share with us all of her experiences, but specifically in the area of nursing and her time on the State Board of Nursing. Thanks for being here.
Oh, absolutely. Thank you for having me. I'm really excited about this topic in all honesty. And I have a handout for you. And this handout is available online if you're interested. It's the Kansas State Board of Nursing 2023 annual report. There's nothing really magic about this. And honestly, there's one page in there that I'd like to refer you to. It's page 11. And if you go to the KSBN website, it's certainly available there. I really appreciate this opportunity. Nurse staffing is a big issue across the state, but then it becomes an even bigger issue when you start specifying with behavioral health. I've been a nursing administrator for almost 20 years, and I've been on the State Board of Nursing now for a little over 6. One of the topics that we've talked about is the licensed mental health technician, and I want to focus on that. And on page 11, you'll see the statistics, and this was at the end of our fiscal year 2023. We had 37 licensed mental health technicians in the state of Kansas, and I want to talk a little bit about that. You heard from Lynn Loveland, there are no programs. That is very true. The only program is in Osawatomie State Hospital, and they have one as they need to. And honestly, I would tell you that personally, I see that as a best practice. I had the opportunity in December of 2022 to go and participate in the Osawatomie State Hospital annual survey it's not annual, I'm sorry, their regular survey from the State Board of Nursing. And what they do is they have their hired employees go through a curriculum that's been approved by the State Board of Nursing. The recommendations from the State Board of Nursing at that time for Osawatomie was to partner their curriculum with a university so that those students could earn college credit and start building that pipeline. So it would be the licensed mental health technician, and then being able to go on to an LPN school, and then eventually an RN school. There are 2 courses that are required in that LMHT curriculum by the Kansas State Board of Nursing, and they are entry-level courses for nurses. So the State Board of Nursing has left that license specifically to see that pipeline be built for mental health. When I first joined the State Board of Nursing, when I was asked to be a member, there was a discussion, do we close that license? Because there are so few in the state. And we did not do that. We've shied away from that conversation in hopes that someone will push that forward. There is 37 right now. The way that licensure works is that it comes up for renewal in December every 2 years of an even year. So in 2022, we saw 22 licensed mental health technicians not recertified. That number dropped at that point to 37. Of those 22, 2 of them went on to a higher level degree. I think one became an RN and one became an LPN, I believe. The others potentially left the field. Some of those were of retirement age, some were not. These are entry-level positions, so they don't make a lot of money. Most of those folks are consolidated around the Osawatomie State Hospital area because these aren't folks, I mean, usually they're not the breadwinner of their family. They're not moving for their job. Osawatomie State Hospital did do a site, a facilitated site at Larned for a while. They tried to do another LMHT program at Larned. It never really got wind and took off, and they have since closed that. So the only site is at Osawatomie. About a year ago, forgive my timeline, it may have been a little more, a little less. COVID still messes up my timelines, but we did see KVC, it's now Chamber Mental Health, come to the state board and ask to initiate an LMHT program. Again, this is a private hospital. It's not partnered with a college, a university to get curriculum credit for their students. They took that suggestion though, and they are preparing to graduate 15 to 20 students this April 2024 was when they will let their first class come. So I think the LMHT program is an opportunity to start building that pipeline. I also want to talk about one other thing, which is the apprenticeship. As the state board has been asked several times to consider developing a license for apprenticeship, and the position that we have taken, and in fact, I think it was at our October board meeting, we voted specifically to support apprenticeship programs. What we would like to see hospitals partner with universities to develop those apprenticeship programs. There is a lot more regulation and legislation, and that all takes time. And then it's more government regulation coming down to manage those relationships, which we feel like the Kansas Nurse Practice Act is really clear in how students can function, how you have delegation can happen. And we would encourage that not to become a government regulated license, but to allow hospitals and universities to develop those partnerships and do that. And that was voted and supported by the Board of Nursing. I believe it was at the October meeting. So in conclusion, as a nursing administrator, I will tell you that that is what I am doing. I have identified 2 universities, and we are in our infancy. I've been at Providence now just 1 year. We are in our infancy, but we are looking to develop partnerships and apprenticeships where we can bring students in. I want to be clear that Nurse Practice Act does not say anywhere in it that nursing students, LMHT students, cannot be paid for their clinical hours. So there are a lot of things that I think are perceived to be there that may or may not actually be correct. But I think apprenticeships and the growth and development of this LMHT program in partnership with a university where students could get clinical hours and clinical credit and then grow on to a healthcare career. So Osawatomie and Larned currently do not offer that college level credit, but they are essentially college level courses that they are sitting through. So those are my recommendations. I'm certainly open for questions, and I hope this whole packet is really a lot about nursing and nurse numbers across the state. There's some interesting information in here, but specifically page 11 was the one I wanted you to see.
Do we have questions?
I do have a question about apprenticeships then. So it would be a nursing student that would be working in your case, in your hospital, under the direct supervision of another nurse, or what would they be able to do in that apprentice role?
So there's
what's your vision of what they'd be able to do in that role?
So the Nurse Practice Act is pretty vague when it comes to some of the specifics of what an apprenticeship program would look like. There are some very clear languages around delegation. And so that's exactly what that would look like. So is it an instructor possibly employed by a hospital? And maybe, we talked about the pay of faculty. So an instructor may be employed by a hospital and functioning in a hospital employment pay structure, and then overseeing students And there's partnerships in developing that curriculum. I will tell you that there is a hospital here in town that has partnered with Galen College, and they are really on a cutting edge. They're the first we've seen in the state of Kansas. They came to the Board of Nursing and asked for approval of that program, and it's the first we've seen in the state of Kansas. But they have what I would call the development of an apprenticeship program and the way that they're operationalizing their nursing students within the workforce at different levels and growth.
Thanks for clarifying that. Yeah. All right.
Thank you
for
very
bringing
much.
that.
I appreciate you having me.
Thanks for being here today. And if you have mom duties, you can go. She's got a break from a very important wrestling tournament. So there's that. And our last speakers today are Dr. Lincoln and Mike Parmley from the KU campus here in Wichita. So they're going to share their perspective to round out our pipeline conversation.
Hello, everybody, and thank you for having us. My name is Yana Lincoln. I am a psychiatry program director here at University of Kansas, Department of Psychiatry and Behavioral Sciences. This is Mike Parmley. He's a program administrator, I think is the correct term. Dr. Brown, who is our chair, is not here with us today because she is out of town. She had to attend a conference, otherwise she'd be here with us. I think first, I'd like to thank you guys for having us. Second, what I would like to say is that I think everything that was said so far, we agree with and kind of can sympathize with, or probably sympathize with, and basically we are agreeing with everything that was said. So the questions that were provided were pretty broad, and I really was not sure what would be the best way to answer them. So we just decided, let's just take question by question and kind of provide the answers or the information that we thought would be helpful. I did print out some, I brought some handouts as well. I think I didn't bring enough, but I can send the, yeah, okay, thank you. So first of all, I think I like to always start with the historical perspective. So even though we are a 4-year medical school here in Wichita, and we've been established in 1976, not many people know that we are a 4-year medical school here in Wichita. And so, as I said, the school was established and our residency program was established in 1976. At its origin, the psychiatry residency program was actually funded by state. Later on, the funds and the expense was moved on to GME, which is a graduate medical education. Currently, we can say, as we reviewed our roster of alumni, we trained more than 250 psychiatrists here in Wichita, and we graduated 225. So out of those 225, more than 60 stayed in Kansas. And if we count Northern Oklahoma and Western Missouri, 80 of them we were able to retain. When the residents leave and the ones who don't stay, most commonly they come here for training and then they choose to continue their education or their training in different psychiatric subspecialties, and they will move away from the state, or they are not Kansas born and they just go back to their families. So the residents, when we were kind of looking at the residents that we retained, most commonly are the ones who have ties to the community, who have their support in here, either get married here or come from here. Second time of the resident who stays or graduate who stays as the person who does not have ties to anywhere else. And so this is where I'm going to say, and you will hear from my accent, I am not American. I was born in Eastern Europe. I was born in Czechoslovakia. Now I'm from Slovakia part, but I married an American guy, and so here I am. And so majority of our psychiatrists who were able to stay in Wichita just kind of fell in love with the community, like to raise their families in here. And portion of them are actually foreign medical grads that we trained. I would like to say that our department is also kind of formed mostly from our graduate, and with the exception of 3 faculty members, everybody else on psychiatry side was actually trained by us. We also provided a lot of psychiatrists to community mental health center ComCare. I think all of them, right, Joan, are trained by us. Same would be true for VA. And as of now, we have 4 psychiatrists, our graduates, me being one of them, providing care to the patients in the Larned State Hospital. Currently, our adult division has general psychiatry psychiatrist. We have psychology and neuropsychology support. We have everybody is board certified and licensed in their specialty, because that is a requirement, national requirement, if you want to be on a faculty and teach the other trainees. We and our psychology department collaborates pretty closely with the Wichita State University Department of Psychology. And to just kind of say, psychiatry residency is not the only residency that KU has. KU has 4 different residencies, but also has a department of Wichita Council for Graduate Medical Education. And that council manages multiple other residencies. Some of them are actually owned by private groups. Those are mostly surgical specialties. The reason why I'm saying that is because this council, we call them WIGME, Wichita Council for Graduate Medical Education, makes sure that we all are following the national requirements for the residency trainings. And that's very important, because if you do not graduate from accredited program, you are never going to be board eligible. And so that's kind of a disjustice to our graduates. Just to speak a little bit about our residents, I think they all feel that they get a high quality of education. Several of our faculty is known nationally. When they graduate, they practice in all sorts of settings. They practice in state or private inpatient hospitals. They practice in outpatient settings. They practice in different nonprofit organizations or VA. Some residents who graduate from us or fast track to the child and adolescent fellowship are able to match to highly competitive programs like in Yale or Emory, University of Texas, UCLA, UC Davis. And so I think that just speaks to the quality of the education and the training that we provide. So the question number 2 was, what barriers are we experiencing? So our main barrier is really a recruitment of the faculty and retention of the faculty. When you are working in an academic center, you have to, and when you are part of the educational process for the medical students or for the residents, you have to not only be clinician and clinically productive, but you also have to be able to maintain certain level of educational standard. And that comes, of course, with a lot of paperwork. And so the other well-known fact is that when you work for the academic center, the salaries, and I've heard this now several times, salary for the teaching faculty is not competitive with the salary of the private institutions or VA or even community mental health centers that they can provide. So now you have a additional burden that is associated with the, let's say, paperwork of the educational process, and also a clinical requirement with the salaries that are lower. And that becomes problematic when we need to recruit the faculty. So really, most of our faculty is here because they just love teaching and they love to be involved in with the academic institution. However, when you have a lot of work, and you are having troubles to take a time off, that does lead to burnout, and then the retention becomes difficult. So to talk a little bit about what Dr. Mayorga and Dr. Gabriele already talked about, and that is the interest in a psychiatry as a medical specialty. So that is true. We every year get between 750 to 800 applications for our residency spot. Out of those, we will invite 75 applicants for the interview. Out of those 75, we will choose 6 that we believe are the best fit for our program and for our community. So that tells you that there is a huge interest in psychiatry as a specialty, but we do not have enough of training spots. Dr. Gabriele already mentioned that we are retiring psychiatrists faster than we are producing them. That is true. It is difficult to maintain even the situation, and the situation is not good. We want to improve it, but even the maintenance of the current situation is going to be difficult because more people will retire that we are able to train and retain in here. So that we consider as another barrier, that we just do not have enough of training spots. And as Dr. Mayorga said, that is very much attached to a funding. And so the GME funding is set. It did not change for a long time. The spots for the residents are not going to increase. And so that creates a tremendous difficulty for all of us. Are there any policies or policy solutions for the state level that could help? Well, the other not best kept secret is when you graduate medical school, you have a huge amount of the medical student loans. It is not uncommon for a medical school graduate to have anywhere between $300,000 and $500,000 in student loans. So when you are now needing to start to pay your loans, we are in a residency program that the salaries for the residents are not very high. And then when you graduate, it is very important to start to look for the job that is going to help you to pay for those student loans. And so if the state can help out with either loan forgiveness or the loan repayment programs for these residents who would stay here as a graduates, as a part of the incentivization, I think that would help tremendously to retain more psychiatrists here in this area. Same would probably go the financial support for the teaching faculty. It is hard to recruit. It is also very hard to retain, because when you graduate, a majority of the, or a big chunk of the graduates will stay and practice in the area where they graduated from. However, the next kind of round around is about 2-3 years after you practice already. And when you start to, you got your feet wet, you passed your boards, you start to look for the opportunities that maybe better suited for you. So that's where the retention comes in. So recruitment and the retention is very much attached to the salaries that we are able or unable to provide for the faculty. Do other states address kind of shortages, educational issues in a way that panel could research? Yes, there are multiple states in the United States that the states actually support the residency programs. Just off the top of my head and from my friends, other program directors across the country, Michigan is one, Nebraska is another one, California is another one, New Jersey, Iowa. Iowa was probably the last one that implemented this about a year ago, but that's a place to go and probably research what mistakes need to be avoided. They implemented the program, but the programs were not in alliance with the accreditation requirements. And so that created a lot of issues because through everything went through the legislature, and to fix the mistakes was very costly and delayed a lot of things. What are you hearing from the pre-service folks? So we can say by the experience that the interest in psychiatry as a medical specialty is increasing. We know that based on what we are seeing with our medical students. But I can also go and pull the numbers from National Residency Match Program, and they tell us how many spots there are, how many were filled. And so just to give an example, in 2019, we have 298 programs, psychiatry residency programs. In 2023, we had 379. So in a span of 5 years, the United States added 81 programs. The number of the positions for the PGY1 in 2019 was 1,740. In 2023, 2,164. So 424 positions added. In Kansas, we didn't have any. So in the past, actually in Kansas, almost 10 years, we were not able to increase number of positions for the training. It's all tied to finances. So according to this webpage that I just referred to, Kansas City has 9 positions for PGY1, so we have 6, and that has not changed for probably close to 10 years. I think we were the last ones, and Dr. Gabriele and Dr. Mayorga, correct me if I'm wrong, I think we were the last ones who were able to increase the positions was almost 9 years ago when the VA helped us to fund one extra position, but there were no other changes. So one more thing, what else do we think would be helpful to add? This is where as I said, I'm one of the providers of the care in a Larned State Hospital. I work on a forensic unit. And I can tell you that the patients in the state hospitals are the sickest patients that we have. Because of that, it is very important to understand the pathology. These patients frequently have not only mental illness, but will struggle with substance use disorders, intellectual developmental disorders, different personality disorders, medical problems. It really is only a physician who has enough of training and education to understand the complexity of these patients. And I do think that it is very important that the leaders of these treatment teams needs to be licensed and fully boarded psychiatrists, because these patients are just that very ill. That's not to say that nobody else has a place at the table. Absolutely, everybody else does. The good treatment teams always have not only physician, but they have a good nursing staff, other support staff, psychology and social work, and so the treatment teams need to be composed as such, because if you have a good treatment team, then you can start appropriate treatments early on that then accounts for the efficiency of the care and decreased length of stay. The state hospitals or the state hospital that I provide care in, I always have a resident who does the rotation with me. It's elective rotation because it does not qualify for the full-fledged inpatient rotation. But all the residents find it very helpful and very educational, because not only they learn about severe and persistent mental illness and the other comorbidities that go with it, but they also learn a lot about the forensic side, not only on a civil court side, but also on a criminal court side. They find it fascinating. A lot of them, actually, since we started this rotation, we had 2 residents who developed an interest in a forensic psychiatry, and one of them actually is going to start a fellowship. So that's what I wanted to share with you guys. If you have any questions, we are open to it. If we cannot answer, we'll find out and let you know.
One of the things I wanted to add was that our intention when we do the work groups is to invite all these very knowledgeable folks to participate along with advisory panel members and continue to seek their guidance. Today was a snapshot of that. So do we have any additional questions for the folks from KU here in Wichita?
I do have one question, and forgive my ignorance, but the way I understand it, the residency positions overall are kind of capped or frozen at our existing hospitals. Does the new state hospital afford us the opportunity for that to become a quote teaching hospital to create new residency positions, or no?
You know, I think it is. I am not 100% sure though. This is where I would offer WIGMI to help out with that. They know all these regulatory issues. When you are talking about the residency though, and Dr. Mayorga and Dr. Gabrielli already touched on it, the training is not only the inpatient side. So you have to have a training in other sides, and it doesn't have to be in one hospital. It can be across the multiple hospitals. So when you're thinking about that, when we are expanding, regardless who is going to be funding, the other things need to be part of it.
Any additional questions?
Senator Reddy's got a question.
Oh, thanks for pointing that out.
Yes, thank you. Thank you for all of the presenters. I think the information was overwhelming, but it's also everything we need and such a short span of time. So obviously we have a lot of work to do ahead. But I wanted to know from any of the speakers that spoke today, where would doctors of osteopathy fall into this as in the psychiatric field? I know, we spoke a lot about psychiatrists, and I'm assuming MDs. Where would a DO, or is that something also as an option when we're talking about, like you said, a very intense profession in this kind of a hospitalizations piece of it?
Yeah, a DO and an MD are the same. So they both go to psychiatry residency, work together shoulder to shoulder. So they're a psychiatrist.
So there are two medical schools, allopathic and osteopathic. DO is the osteopathic, allopathic is the MD. When they finish the medical school, they're considered to be equal. And so both, I'm pretty sure Kansas City, we do too, take both. We take MDs and DOs. Really, you don't really look when you are, so how does the whole interviewing process go? You get the application, you review it, you score the applicants. DO or MD does not play a role in the scoring. What plays a role is your academic achievement, your support to the community, your volunteering work, how you present, are you able to develop a rapport relationship